This is Dr. Lori Gardner, and I will be lecturing on substance abuse at Nicholls State University for Nursing 591, 691. This is part 1 of the lecture. The objectives are to understand the importance of substance use in psychiatric practice, the current statistics on substance use disorders in the United States, and the impact on individuals, families, and communities. Substance use. The term is used to describe the wide range of the disorder, from mild to a severe and chronic pattern of relapse and compulsive drug taking. So there is substance use disorder, which is a pattern of signs and symptoms resulting from substance use, and substance-induced disorders, which include substance intoxication, substance withdrawal, substance or medication-induced mental disorders. The essential feature is a cluster of cognitive, behavioral, and physiologic symptoms. This involves a consumption of substances, and it can depend on cultural background, substance availability, and specific local drug regulations. So, what does that mean? Well, different people are exposed to different substances depending on their area. Rural areas tend to have a greater exposure. And then what substances available? Are clients able to get crack cocaine? Are they able to get marijuana? Are they able to get LSD? On a college campus, for example, they may be able to get ecstasy, LSD, cocaine, versus someone in a rural neighborhood who may only have access to marijuana. Also, specific drug regulations. Cannabis, as you know, is legal in some states. It's not in Louisiana, but it is in some states. The diagnosis of substance use disorder is made based on the pathological patterns of behaviors that are related to the substance used. The DSM-5 TR classifies 11 different substances for substance abuse: alcohol, caffeine, hallucinogens, inhalants, opioids, sedatives, stimulants, hypnotics, cannabis, anxiolytics, and tobacco or unknown substances. A substance use disorder is classified as continued, recurrent use and abuse of drugs, including alcohol, tobacco, and caffeine, resulting in clinically significant impairment, health problems, disability, and failure to meet responsibilities at work, school, or home. Diagnosis of a co-occurring psychiatric or mental disorder with substance use disorder requires at least one disorder of each type in independent existence of the other, not simply a cluster of symptoms resulting from one disorder. Alcohol is the most prevalent substance used and abused by adolescents. Adolescent cigarette smoking has been declining, while daily marijuana use has increased. Use of other illicit drugs such as MDMA, opiates, and cocaine and crack have increased. And it's estimated that 12% of U.S. adolescents meet the criteria for substance abuse or dependence. That's pretty high. What are some of the key diagnostic features for alcohol use disorder? A cluster of behavioral physiologic symptoms including withdrawal, tolerance, or craving. Withdrawal signs and symptoms develop within 4 to 12 hours after the reduction of intake following prolonged, heavy alcohol ingestion. They have a strong desire to drink, and it makes it difficult for them to think of anything else. They wake up in the morning and they're already thinking about what they're going to drink. They're drinking throughout the day. It doesn't matter what else is going on. They're looking for their drink, their next drink. School and job performance suffers. Childcare or household responsibilities may be neglected. And they may start to have alcohol-related absences from school or work because they just can't get there, especially if they're hungover or if they're not feeling good from all of the alcohol they've consumed. They have an increased risk of accidents, violence, and suicide. They may show symptoms of conduct problems, depression, anxiety, and insomnia frequently accompanies heavy drinking, and sometimes it may precede it. Repeated high doses of alcohol can affect every organ system: GI, cardio, the central nervous systems. GI symptoms include gastritis or ulcers. It affects approximately 15% of people who use alcohol heavily and may lead to liver cirrhosis and or pancreatitis. There's also an increased rate of cancer of the esophagus, the stomach, and the GI tract. Alcohol use disorder is also associated with low-grade hypertension. So let's talk about intoxication. Anyone with a blood alcohol level of 0.08 is considered to have alcohol intoxication. The progress is from a labile mood. They may have impaired judgment and poor coordination to an increasing level of neurologic impairment, and it can be severe dysarthria, amnesia, ataxia, and they can even become obtunded. Alcohol intoxication can be fatal. Some of the early signs of alcohol withdrawal include anxiety, tremors, headaches, nausea, irritability. They may have hyperactive reflexes, hypertension. They may have seizures, which are generally seen in 24 to 48 hours, and those are most often grand mal seizures. And then, of course, if they progress to delirium tremors, that's between 48 and 72 hours. They may have altered mental status, they may have hallucinations, and of course, that is life-threatening. Now, outpatient controlled drug treatment, that involves supportive education, skills training, some psychiatric and psychological treatment, different medications that we'll talk about, disulfiram, naltrexone, and acamprosate. But when they have severe symptoms, that it requires inpatient treatment. You will not treat that in an outpatient environment. Alcohol intoxication involves a recent ingestion of alcohol, clinically significant problematic behavioral or psychological changes. They may have inappropriate sexual or aggressive behavior, a labile mood, and impaired judgment. that develop during or shortly after the alcohol ingestion. One or more of the following signs and symptoms develop during, shortly after alcohol use, and that would include slurred speech, incoordination, an unsteady gait, nystagmus, stupor, or impairment of attention or memory. Cessation of or reduction in alcohol use that has been heavy and prolonged. Two or more of the following developing within several hours to a few days after cessation, which is also described in criteria A. Now, these are the DSM-5 criteria. They may have autonomic hyperactivity, which is the sweating or tachycardia, increased hand tremors, nausea and vomiting, anxiety, insomnia, transient visual, tactile, or auditory hallucinations or illusions, and generalized tonic-clonic seizures. Now, some differentials for alcohol withdrawal include a non-pathological use of alcohol, sedative, hypnotic, or anxiolytic use disorder, a conduct disorder in childhood, antisocial personality disorder, alcohol intoxication, withdrawal and alcohol-induced mental disorders. And again, management is supportive in the outpatient setting, medications as well. The prognosis is variable, and it just depends on how early the onset is and how severe the alcohol use disorder is. Signs, symptoms in criteria B cause clinically significant distress, impairment in social, occupational, or other areas of functioning, and signs and symptoms are not attributable to another medical condition. Cannabis use disorder, that stems from either the delta-9 THC or THC. And cannabis can be used in many forms. They can smoke it, vape it, dab it. It can be cooked. And it's also in food and beverages. I recently saw a drink. It looked like water, but not, it looked like coconut water, but there was actually THC in that water. Cannabis use disorder equals frequent use, 4 or more days weekly for them to have a cannabis use disorder. The DSM-5 says criteria includes cessation of cannabis use that has been heavy or prolonged, with 3 or more of the following signs and symptoms within approximately 1 week after criteria A. They may have irritability, anger or aggression, sleep difficulty, nervousness or anxiety, restlessness, decreased appetite or weight loss. They may display a depressed mood. At least one of the following physical symptoms associated cause significant discomfort, which would be fever, chills, headache, abdominal pain, or tremors. Treatment. They have differentials, which may be non-problematic use of cannabis intoxication, withdrawal, and cannabis-induced mental disorders. The management for cannabis use disorder includes detox or rehab, which could be a 12-step program, CBT, motivational enhancement therapy, contingency management, which is monitor and remove that target behavior, and treat other psychiatric disorders and symptoms. And the prognosis varies. Tobacco. Tobacco is the most important preventable cause of death and disease in the United States. It affects about 25% of current smokers and 25% of ex-smokers. It is attributable to 20% of all deaths in the United States. 45% of smokers die from a tobacco-induced disorder. Secondhand smoke can cause death and morbidity. Psychiatric patients are at risk for nicotine dependence. About 75 to 90% of people with schizophrenia smoke. Tobacco withdrawal, according to the DSM-5, is a daily use of tobacco for at least several weeks. An abrupt cessation of tobacco use or reduction in the amount of tobacco used, and then followed within 24 hours by 4 or more of the following: irritability, frustration, and anger, increased appetite. They may have difficulty concentrating, insomnia, a depressed mood. They may be very restless, very anxious. The treatment is we use CBT, an agonist substitution therapy like a nicotine gum or lozenges, the transdermal patch, a nasal spray, Zyban, which is bupropion 150 milligrams, and that's given twice a day, or Chantix, which is varenicline, and that is 1 milligram twice a day. There are many smoking cessation programs available, and the prognosis varies. Next, we have caffeine intoxication. That is recurrent consumption of caffeine in excess of 250 milligrams. 5 or more of the following signs or symptoms developing during or shortly after use, and that includes restlessness, nervousness, insomnia, diureses, GI disturbances, excitement, and some facial flushing. Caffeine may also have muscle twitching, rambling flow of thought or speech, psychomotor agitation. They may have tachycardia or cardiac arrhythmias, or periods of inexhaustibility. Signs and symptoms in criteria B cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and those signs and symptoms are not attributable to another medical condition. Some withdrawal symptoms, they may be dizzy or lightheaded, they may have headache, they may be very irritable, they may have some mental fogginess, a negative mood, and nausea and vomiting, or even fatigue. Caffeine withdrawal comes from the prolonged daily use of caffeine, abrupt cessation of or reduction in caffeine use, and it's followed within 24 hours by 3 or more of the following signs and symptoms: headache, marked fatigue or drowsiness, flu-like symptoms, difficulty concentrating, or they may be pretty irritable. The signs and symptoms in criteria B must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and these cannot be attributable to any other medical condition. Some of the differential diagnoses include other medical conditions and medication side effects, or caffeine-induced sleep disorder. To manage this, taper intake of caffeine to wean off, or reduce intake to lower levels. Caffeine withdrawal passes within 4 to 6 hours. Most symptoms are mild with self-care and pain relievers, so you probably will not have someone coming in for treatment for caffeine withdrawal. Stimulants are psychoactive substances that increase activity in the brain, resulting in elevating alertness, mood, and awareness. Stimulants can be amphetamines, prescription stimulants, or cocaine. Usually, patients who take stimulants that don't need them get an instant feeling of well being, confidence, and euphoria, which is why a lot of college students may sell their prescriptions of Adderall. Selling their prescription of Vyvanse won't really do much because Vyvanse is very long acting and has the least chance of any type of euphoria from it. Um, Patients taking stimulants may also have dramatic behavioral changes. The DSM-5 says stimulant intoxication includes the recent use of an amphetamine type substance like cocaine or some other stimulant. Of course, it causes clinical significant impairment. It's problematic behavioral or psychological changes that develop during or shortly after the use of a stimulant. They may have tachycardia, bradycardia, dilated pupils, perspiration or chills. Blood pressure can be either high or low. They may have some weight loss, nausea and vomiting, psychomotor agitation or retardation, muscular weakness, respiratory depression, chest pain or cardiac arrhythmias, confusion, seizures, dyskinesias, dystonias, or coma. You know that some patients that take crack cocaine, one hit, and they may have a lethal cardiac arrhythmia. Stimulant withdrawal is the cessation of or reduction in a prolonged amphetamine type substance, cocaine or other stimulant, a dysphoric mood, and two or more of the following physiologic changes developing within a few hours to several days after criteria A. And that includes fatigue, vivid or unpleasant dreams, increased appetite, insomnia or hypersomnia, psychomotor retardation or agitation. Some differentials include PCP intoxication, stimulant intoxication, withdrawal and stimulant-induced mental disorders. Management includes stimulant treatment support, education, skills, even Cocaine Anonymous, CBT, acupuncture, and antidepressants. And of course, the prognosis varies. For hallucinogens, naturally occurring like the peyote cactus or magic mushrooms, some synthetic agents like LSD. They may have dimethyltryptamine, which is smoked, snuffed, or used IV. STP, which is 2,5-dimethoxy-4 methylamphetamine, or MDMA, which is 3,4-methyl-indioxymethamphetamine, or ecstasy. Hallucinogen intoxication includes the recent use of the hallucinogen, clinically significant problematic behavior or psychological changes that develop during or shortly after use of the hallucinogen, perceptual changes occurring in state of full wakefulness and alertfulness that develop during or shortly after use, and two or more of the following signs: dilated pupils, tachycardia, sweating, blurred vision, palpitations, tremors, or incoordination. Some differentials include other substance intoxication, hallucinogen persisting perception disorder, hallucinogen inducing disorder. Inhalants. That is from inhaling either toxic gases, dry cleaning fluids, felt tip markers, glues, fuels, paint thinners and removers, even those the aerosols used to clean keyboards has been sniffed before. Any volatile compounds, aerosols, or spray paint. There are some deadly risks associated with inhalants, like asphyxiation, coma, choking, convulsions or seizures, fatal injury, accident, suffocation. Some associated features include lingering odors. They may have a perioral or perinasal glue sniffer rash. They may have pernicious anemia, brain atrophy, major or neurocognitive disorders, or other nervous system disorders. Inhalant toxication. That is reduced intended or unintended short-term high-dose exposure to inhalant substances. They may have clinically significant problematic behavioral or psychological changes that develop during or shortly after use of inhalants, and 2 or more of the following signs. Dizziness, incoordination, slurred speech, nystagmus, unsteady gait, lethargy. They may have depressed reflexes, tremors, generalized muscle weakness, stupor or coma, euphoria, blurred vision or diplopia, and tremors. Differential diagnoses include inhalant exposure, inhalant intoxication, and other substance use disorders. Management, of course, is supportive, CBT, and antidepressants, and the prognosis for this varies. Some differentials include inhalant exposure, inhalant intoxication, and other substance use disorders. Treatment includes support, education, skill management, CBT, and antidepressants, and prognosis varies. Opioid intoxication. Recent use of an opioid, of course. Clinically significant problematic behavioral or psychological changes that develop during or shortly after opioid use. Pupillary constriction and 1 or more of the following. Drowsiness, slurred speech, impairment in attention or memory, and specify if it's with a perceptual disturbance. Opioid withdrawal, according to the DSM-5, presence of either of the following. Cessation of or reduction in opioid use that has been heavy or prolonged. Administration of an opioid antagonist after a period of opioid use. Criteria B includes 3 or more of the following. A dysphoric mood, lacrimation or rhinorrhea. People who sniff opioids usually have that, they're always sniffing like it's allergies. They may have diarrhea, profuse diarrhea, yawning, fever, insomnia, nausea and vomiting, muscle aches. Opioid use disorders, some of the features are regular patterns of compulsive, prolonged self-administration of prescription opioids or illicit opioids like heroin or fentanyl related. These patients typically use enormous amounts or they are purchasing it from the streets, getting someone else's prescriptions. They may experience tolerance, experience withdrawal when they try to stop it or reduce the amount they consume. Their activities are planned around obtaining or administering opioids. So everything they do, they're thinking about, like Roxy's, how are they going to get it? When are they going to use it? They neglect everything else besides that. I mean, they will not go to family functions. They won't go to work. Everything is centered around obtaining these opioids. And of course, opioid overdose can be fatal. Some differentials include opioid intoxication, withdrawal, independent mental disorders, and other substance use disorders. They may need, of course, support, skill building, motivational interviewing, and motivational enhancement therapy. Include family therapy because the families are normally affected at the same rate as patient. CBT is also indicated. Some medications include methadone, which is an opioid substitution, naltrexone, or buprenorphine, or Suboxone, which is an opioid substitution. Sedative, hypnotics, and anxiolytics require the recent use of a sedative, hypnotic, or anxiolytic. Also, clinically significant problematic behavioral or psychological changes that develop during or shortly after sedative, hypnotic, or anxiolytic use. And one or more of the following: slurred speech, incoordination, nystagmus, impairment in cognition, unsteady gait, and stupor or coma. Again, they may have repeated absences or poor work performance, significant levels of tolerance and withdrawal. They may have intense cravings, and these are usually associated with other substance use disorders as well. Now, sedative, hypnotic, or anxiolytic withdrawal. The criteria is cessation of or reduction in the sedative, hypnotic, or anxiolytic use that has been prolonged. 2 or more of the following developing within several hours to a few days after they stop using would include autonomic hyperactivity, hand tremors, anxiety, maybe a transient visual, tactile, or auditory hallucinations or illusions, insomnia, grand mal seizures, and specify if it's with perceptual disorders. Some differentials include sedative, hypnotic intoxication, withdrawal or alcohol use disorders. Treatment is supportive, education, skill building, motivational interviewing, and motivational enhancement, CBT, family therapy, and antidepressants, and the prognosis varies. How does this impact our patients? Well, they may have a social impairment. They may have risk-taking behaviors, things that they would not have normally done, driving fast, getting involved in violent crimes, stealing because they're trying to get the funds to fund their habit, ability or inability to control usage amounts, and level of drug tolerance and severity of withdrawal episodes. Of course, these substances produce pleasure, euphoria, and that euphoria is referred to as their high. So about 48.7 million United States residents have a substance use disorder. 29.5 million have alcohol use disorder. 27.2 have a drug use disorder. 168.7 million use tobacco products, and another 8 million have alcohol use disorder and a drug use disorder. It is estimated that over 50% of people with mental health disorders and serious mental illness also have a co-occurring substance use disorder. Globally, alcohol, tobacco, and illicit substances use is directly and indirectly responsible for 11.8 million deaths per year. For substance use disorder criteria, they must meet at least 2 of 11 criteria over a 12-month period. The specifiers can be a mild disorder where they have the presence of 2 to 3 symptoms, a moderate disorder where they have the presence of 4 to 5 symptoms, or a severe disorder and that requires the presence of 6 or more symptoms. It includes taking substances longer or in larger amounts than intended, unable to cut down or stop use, spending time obtaining, using, and recovering from the substance of choice, experiencing cravings, intense desires or urges, failure to fulfill obligations at home, work, or school, feelings of withdrawal, continuing substance use despite any problems that it's causing, giving up social, recreational, or occupational activities. They're no longer concerned with hanging out with friends unless those friends are using, going to work because they're trying to get the substance. They don't worry about family events or functions. Their main goal is using, how they're going to get it, when they're going to get it. Once they get that high, it starts all over again. Using substances in risky or dangerous situations. They may have overdosed once before, but guess what? They're going to do it again. They're going to use that substance again because they want to get that high. So they know it's risky, but they're still going to do it. Continuing substance use despite having any physical or mental problems. Intolerance, needing more to achieve the previous effects. So they still, once they get it and what they're using is not producing that high, they've got to have more of it. Here's some of the etiology. Where psychological, they may have comorbid psychiatric disorders that are associated with an increased risk of substance use. Biological, where it may cause increased risk of mental illness in adulthood. Sociocultural, more prominent in certain population groups. Genetic makeup for stress response predisposes the risk of dependence on substances. Can be traumatic events that take place during childhood that cause a genetic changes passed through generations. And environmental or stress or trauma cause a genetic changes passed down. Science estimates that genes, including effects on environmental factors, have on a person's gene expression or epigenetics account for between 40 and 60% of a person's risk of addiction. Environmental factors such as personal history of divorce, death, criminal activity, and alcohol problems at home strongly predict the risk for drug abuse in both adoptive and biological children. So in neurobiology, the brainstem controls functions critical to life, of course, breathing, heart rate. The limbic system is the brain's reward system, and that's influenced by emotion. The cerebral cortex is the reasoning center of the brain. It controls hearing, feeling, and tasting. Dopamine in the gamma aminobutyric acid or GABA. So the neuroadaptive process increases when the substance use stops. Withdrawal symptoms develop because adaptive responses are unopposed when the substance is removed. And neuroadaptive changes may be longer for some people. After long periods of sobriety, a person often picks up at the same level of tolerance and physical impact they had before sobriety. Okay, this is the end of substance use disorders, part 1.